Hello, everybody. We are happy to talk with you with hereditary ATTR amyloidosis. I'm David Adams from Paris in France, and I, with my colleague Marcia Waddington-Cruz from Rio de Janeiro from a reference center in Brazil. Next slide. As hereditary amyloidosis with transthyretin, as you can see, it's a hereditary. It's autosomal dominant transmission as from parents to children, 50-50 from the both sex, and there is it's adult onset affecting adults from age 20 to more than 85. It depends on the mutations and the country. As you can see, more than 100 variants in the TTR gene, a small gene of 4 exons. Next slide. The main source of production of the transthyretin prealbumin is the liver. So production of transthyretin and as a tetramer and dissociation produce amyloid deposits in different tissue. The main one is the peripheral nervous system in the lower limbs, upper limbs, and also the heart. And the main manifestation is sensory loss, weakness, and dysautonomia. As you can see, amyloid deposits in nerve on the left side of the slide. Next slide. This is the main clinical manifestation. This is a systemic disease and a life-threatening disease. For autonomic manifestation, you can have orthostatic hypotension, urinary tract infection, and sexual dysfunction, very early stage, early satiety, diarrhea, severe constipation. Majority have involuntary weight loss, bilateral carpal syndrome, and altered sensation or motility in the forelimbs. Gaze disturbance is the main problem, and loss of autonomy of the forelimbs. You can have also cardiac manifestation with conduction block, cardiac arrest, dyspnea, cardiomyopathy, and arrhythmia. Also, kidney manifestation with renal deficiency, and ocular manifestation, the main one, glaucoma and vitreous opacities. Next one. This is a progressive disease. That means you start with paresthesia and abnormal sensation in the feet, and progressively you develop difficulty in walking, and you need, after 2 to 5 years, you need an aid for walking, 1 crutch or 2 crutches, and finally you are wheelchair bound and bedridden after 7 to 10 years. So very severe and disabling neuropathy. Next one. The management of hereditary ATTR amyloidosis is very complex. You need a multidisciplinary approach. Once you have done the diagnosis, you have to assess the sensory motor neuropathy with different scale, to what autonomic involvement you have with different scale also, and to see systematically, even if complain of neuropathy, to see what's happened with the heart, with different investigation for conduction or cardiomyopathy, also for kidney and eye. And then for the therapy, you propose symptomatic therapy to control the pain, for example, for rehabilitation, for treatment of different autonomic dysfunction, diarrhea, erectile dysfunction. And of course, you need to start anti-amyloid therapy to control the production of the amyloid with either TTR stabilizer, patisiran, inotersen, or liver transplantation. Of course, in some cases, when severe organ involvement, you need sometimes pacemaker, dialysis, kidney transplantation, heart transplantation, or ocular therapy. Of course, the family is very important. Previous one, the genetic counseling is very important for detection in the brothers and sisters and the children, TTR gene testing to detect which one are carriers of the mutation, which are candidates to develop the disease in the next years. Next one. There is a large phenotypic heterogeneity in clinical presentation, and for the neurologist, it's not so easy when you don't have family history in late onset. It presents like CIDP, like motor neuropathy, or eventually upper limb onset polyneuropathy, which render the diagnosis sometimes very difficult. Next slide. The two diagnostic tools, you need genetic testing to see if you have one pathogenic mutation. You can do. Also, you have to find amyloid deposit with biopsy, and we try to develop mini-invasive biopsy in the skin or in the lip, or if to detect cardiac amyloidosis with cardiac DPD uptake, as you can see on the bone scintigraphy, you can see deposits in the earth, and you detect without any biopsy amyloid deposits in the earth. Next slide. When you come back 30 years ago, there are essentially in Europe, in Sweden, in Portugal, and also in Japan and Brazil, the only main countries with this disease. But now maybe this is a global disease, and maybe every country and every continent we know it's a worldwide disease. It seems to be 10,000 cases with hereditary neuropathy and 40,000 cases with cardiopathy hereditary with ATTR. Next slide. This is many therapeutic approaches developed during the last 30 years. First one was a liver transplantation to remove the source of mutant TTR. After that, it was a TTR stabilizer with Tafamidis to avoid TTR dissociation in monomer and production of fibrils. And recently, it was TTR gene silencers for RNA interference and antisense oligonucleotides to block production of both mutant and wild-type TTR. Next slide. This is the biomarker TTR in the serum to show with patisiran RNA therapy. When you with infusion, IV infusion, you can have a knockdown of the serum TTR for both mutant and wild-type TTR, and using stabilization of the disease. Next one. This is the different therapies we can have in the world. TTR stabilizer Tafamidis 20 milligram since 2012. More recently, Tafamidis 61 milligram in 2019. RNA therapy with patisiran, it was in 2018. Inotersen as oligonucleotide antisense in 2018, and liver transplantation since 30 years. And the different indication we can have, some for stage 1 neuropathy, for example, for Tafamidis. For stage 1 or 2 neuropathy, we have patisiran inotersen. And there is very exception of for liver transplantation. This is a very uncommon indication. Now we have 4 different drugs. And for the cardiac amyloidosis, we have only for hereditary high dose of Tafamidis. So recently. Next. This is the progress we have done for ATTR amyloidosis during for neuropathy and overviews during the last 30 years, and with nothing to propose before 1990. After liver transplantation, after 1990, in some of cases. After that, with clinical trials to confirm Vandakel Tafamidis for stage 1, and more recently, we have inotersen and patisiran. So majority of patients with stage 1 or stage 2 can have access theoretically to disease-modifying therapy. So in conclusion, hereditary disease, ATTR amyloidosis is a hereditary disease due to a point mutation of transthyretin gene with autosomal transmission and adult onset. We switch from an endemic and hereditary disease to a worldwide disease now. The main manifestations are sensory-motor, autonomic neuropathy, and cardiopathy with poor quality of life. This is a progressive disease with fatal outcome without any specific therapy. Diagnostic tools are genetic testing and mini-invasive biopsy or DPD scintigraphy. This is now a treatable disease with 4 disease-modifying therapies for ATTR polyneuropathy, and there is one disease-modifying therapy approved for ATTR cardiomyopathy. Genetic counseling is crucial to detect carriers, an early onset of the disease, and start early disease-modifying therapy. Thank you very much for your attention.
Hello, I'm Marcia Waddington Cruz. I am in charge of a National Amyloidosis Referral Center at the Federal University of Rio de Janeiro. I congratulate the organization for this symposium, and thank you very much for the invitation. Next slide, please. Next one, yes. So this is the level of access of Brazilian patients actually to drugs, considering the population and the prevalence of cases that we estimate to have in our territory. Next slide, please. The first medication that was approved in Brazil by Anvisa, our FDA, let's say, was Tafamidis in 2016 for polyneuropathy. And that time, you used to see boxes that came from other countries like Germany. Next slide, please. Tafamidis was really distributed by the public health system since 2018, and now you see the new box, the new green box that is distributed by bought and distributed completely for free by the patients by our Ministry of Health. This was a very important work that was done between me and my center and Fabio, the president of the Brazilian Patients Association. It was a very important group work until we get this drug approved and fully distributed. Next slide, please. Tafamidis for cardiomyopathy at the dose of 80 milligrams is approved by our regulatory agency, Anvisa, since December 2019, but it's not yet distributed as for polyneuropathy. So I have only one patient in a post-study access taking this drug at this dose for cardiomyopathy. Next one, please. Pfizer sent me this official access situation in all over Latin America. So for Brazil, I have already described. In Argentina, Tafamidis 61 milligram is approved uncommercialized. In Mexico, Tafamidis 20 milligrams is approved for polyneuropathy, but not commercialized. Vindamax, Vyndaqel at the dose of 61 milligrams for cardiomyopathy is not approved. In Chile, Tafamidis is approved but not commercialized. In Colombia, Tafamidis is approved for polyneuropathy but not commercialized, and for cardiomyopathy is under approval evaluation. So we see the situation is not ideal, and this is only in some countries in Latin America. Next one, please. As for Tegsedi in Notersen, it's approved by Anvisa in October 2019 for both stage 1 and stage 2 polyneuropathy, but not distributed by the government. It's not bought and distributed by the government. We have no reimbursement of drugs like in other countries. They had a lot of discussion with the Ministry of Health to achieve the price level 1 that was recently accepted in October 2021. So we think that now we'll begin a new round of discussions around incorporating this medication in our protocol and having the Ministry of Health freely distributed all over the country. I have 10 patients that took part in the original trial in a post-access study, and other X patients using by judicial process. It's not approved in Latam outside Brazil, and it was submitted to INVIMA in Colombia and expected approved by the end of 2022. Next, please. As for Onpattro, patisiran, it was approved by Anvisa in February 2020 for both stage 1 and stage 2 polyneuropathy, but it's not distributed. It's the same situation as for Tegsedi. So they got price level 1, and now they will discuss the incorporation into our guidelines and then distributed all over the country. From the open label study, I still have patients that are going to the post-access, but only 3 patients, and other X patients are using Onpattro by judicial process. I guess not too much. Next one, please. Dr. Fabio Barroso sent me this situation in Argentina. Currently, there are 3 approved therapies: Tafamidis 20 milligrams, Tafamidis 80 milligrams, and patisiran. Inotersen is also being used and approved as compassionate therapy. All of them are usually covered by private insurance or obras sociales, worker unions administered by health insurances, but generally after legal fights initiated by the patient, so it's a hard way. And cardiologists are using Vindamax for cardiomyopathy. Next, please. I just want to thank you for your attention and say that I used to take patients inside trials as much as possible, because as this very dear patients that are under ILUS trials and transform trials, because I know how hard it is for them to get access in commercial use, in real world, real life practice use. So thank you very much for your attention. Thank you very much for the patients, for the courage, and for their strong fight together with our center for the access of all these drugs. Thank you very much. Liana, bom dia, boa tarde a quem estiver nos assistindo. Eu gostaria de perguntar a vocês, assim, como representante dos pacientes, o que você considera que seja o maior desafio que os pacientes estejam enfrentando nesse exato momento?
Olá, doutora Márcia, é um prazer falar com a senhora novamente, nossa companheira, parceira de tantos trabalhos no Brasil e também fora do Brasil. Obrigada pelo convite, pela participação, e obrigada a todos. Doutora Márcia, hoje o que a gente percebe no Brasil é a dificuldade de acesso, primeiramente ao diagnóstico, né? A primeira dificuldade do paciente brasileiro é conseguir obter o diagnóstico em tempo hábil para conseguir o tratamento também, antes que a doença evolua demais, antes que aconteça uma evolução muito rápida e que possa causar transtornos irreversíveis para os pacientes, né? Transtornos que eu digo seriam os sintomas, né, que são graves e irreversíveis. E também temos hoje dificuldade de acesso aos tratamentos. A gente já conhece os tratamentos que existem, nós temos as informações, o conhecimento. Hoje a gente trabalha com apenas o Tafamidis ainda no Brasil, que é dispensado pelo governo federal através do SUS, que os pacientes recebem gratuitamente, mas a gente gostaria de ter acesso aos novos medicamentos que vieram depois dele, que a gente conhece hoje no Tercem, o patisiran, e tem outros que a gente já sabe que estão em estudo ainda, mas que ainda não estão registrados no Brasil ainda para serem aprovados para comercialização. Então, a nossa dificuldade grande é acesso ao tratamento. Depois da dificuldade do diagnóstico, é o acesso ao tratamento. E também mais informações, mais médicos que conheçam a doença, que saibam tratá-la. São as maiores dificuldades que a gente enfrenta hoje. A senhora está sem som, doutora.
Ok. Obrigada, desculpe. Quais são as esperanças que você tem para o futuro, Liana? O que você espera, por exemplo, que a iniciativa desse dia de mobilização mundial pela amiloidose traga em termos de conscientização? Qual é a sua esperança para o futuro?
Assim como nós já fazemos aqui no Brasil, há bastante tempo já, desde das gestões passadas, da diretoria da BIPAR, juntamente com médicos como a senhora e outros médicos que trabalham com esse tema, eu acho que a divulgação é sempre muito importante. A BIPAR já faz isso há muito tempo e a gente conseguiu dar uma certa visibilidade ao nome da doença, e levar um pouco mais de informação, tanto aos pacientes quanto a alguns médicos também que não conheciam, passaram a conhecer a partir desse trabalho. E agora parece que essa visibilidade se amplia a partir do momento que a gente tem também essa parceria, esse trabalho em conjunto com outros países, com a Aliança Internacional. A gente percebe que isso toma um corpo ainda maior e é muito importante que isso aconteça, porque a ideia é justamente essa, tornar o nome da doença amiloidose hereditária assim, uma coisa menos estranha, menos esquisita, porque como aconteceu antigamente com doenças como diabetes, por exemplo, e hoje é tão comum, todo mundo sabe, todo mundo pelo menos já ouviu falar, a gente gostaria que a amiloidose chegasse perto disso, para que as pessoas tivessem mais conhecimento e pudessem correr atrás do seu diagnóstico, do seu tratamento, caso ela se apercebesse desse nome dessa doença e que talvez fosse o caso dela. Então, a visibilidade se torna maior, mais ampla, quando a gente trabalha numa parceria tão grande assim, uma parceria praticamente global, né? É muito importante.
Isso, Liana, concordo inteiramente. E você gostaria de fazer algumas perguntas a mim agora?
Tanto como paciente quanto como presidente da associação, a gente sempre tem muitas perguntas, doutor, e sempre é bom poder contar com informações de pessoas que conhecem tanto, sabem tanto quanto a senhora. Hoje, uma pergunta que é nos feita frequentemente na associação e que eu também tenho essa dúvida é sobre o tratamento para os transplantados. Existe algum trabalho em cima disso? Existe algum estudo em cima disso? Alguma esperança para aqueles transplantados, mesmo o transplante de fígado quanto o transplante cardíaco?
Moliana, obrigada pela pergunta, né? Eu não me apresentei adequadamente no início, mas acho que a maioria me conhece pelos anos em que eu já milito nessa causa, já são mais de 30 anos, e eu sou responsável por um centro de referência amiloidose que funciona no Hospital Universitário da Universidade Federal do Rio de Janeiro, chama-se CEPARM. Com relação ao tratamento do paciente já transplantado, no Brasil não existe nada já aprovado ou mesmo dispensado. Muito embora nós tenhamos certeza que esses tratamentos pudessem ser benéficos para evitar a progressão da doença, que já sabemos que acontece depois do transplante hepático, mais especificamente no coração, no olho e no sistema nervoso central, nós não temos à disposição ainda. E existem estudos fora do Brasil, com Onpattro, com Inotersen, mesmo com Tafamidis, mas são estudos isolados. Eu desconheço que qualquer um desses tratamentos esteja de fato aprovado e dispensado para essa condição. Até onde eu sei, são estudos clínicos que, em paralelo, vêm acontecendo com essa população de transplantados. Especificamente, conheço melhor, que foi apresentado nos últimos congressos da Peripheral Society e outros, o uso do Onpattro ou Patisiran para paciente transplantado. Então, nós temos muita vontade, existe um racional muito grande, nós temos muita vontade de poder usar, mas existe uma dificuldade grande de aprovar os medicamentos novos, né? Só o Tafamidis, na realidade, que é uma realidade no Brasil, e para a polineuropatia, menos ainda para a América Latina, e quase sempre as agências reguladoras acham que o paciente já transplantado já está tratado. Então, temos um caminho aí longo pela frente de convencimento, no sentido de que eles necessitam de um tratamento adicional além do transplante hepático.
Doutora, o que nós, pacientes, podemos esperar para o futuro próximo no Brasil, em questão de tratamentos, de novas tecnologias, alguma novidade? A gente pode esperar, aguardar alguma coisa nesse sentido?
Eu acho que sim. Primeiro, nós vencemos uma barreira muito grande, que foi a da aprovação do Tafamidis, da incorporação do Tafamidis no Sistema Único de Saúde, à medida que ele é distribuído, né, sem custo algum em todo o território nacional. E isso para polineuropatia, para cardiomiopatia, ele está aprovado, está ainda em fase de negociação, de incorporação e dispensação. E com relação aos silenciadores, o inotersen e o patisiran, eles já venceram algumas etapas também. Eles estão aprovados, plenamente aprovados pela nossa agência regulatória, que é a Anvisa. Já houve uma negociação de preços que tornassem viável, de fato, a comercialização no Brasil. Isso já foi uma etapa importante, porque, como você bem participou, a questão da categorização da faixa de preço seria muito importante para viabilizar a comercialização ou não desses medicamentos. Então, já houve um convencimento por parte das agências regulatórias de que realmente existiam necessidades não atendidas unicamente com o Tafamidis e que, portanto, esses medicamentos trazem um adicional, um plus, e merecem ser categorizados de uma forma diferente na questão da precificação. Mas agora vão ter que passar por uma série aí de debate de preço até se chegar a um preço final. Em paralelo, nós vamos ter que trabalhar na inclusão desses dois medicamentos no protocolo clínico e de diretrizes terapêuticas, né? As coisas andam em paralelo, mas eu acho que já vencemos algumas barreiras. Uma outra esperança de futuro, bastante promissora, eu acho, é o fato de que não existem mais poucos estudos clínicos, existem muitos estudos clínicos no Brasil. Quando eu iniciei com o Tafamidis, era o único centro no Brasil a poder realizar um estudo clínico, enfim, ter se interessado, e já com esses novos medicamentos, inotersen, patisiran, e agora com o estudo do Hélios e com o neurotransforme, cardiotransforme, Apollo B, Hélios B, nós já vemos uma multiplicidade de centros Brasil afora sendo capazes de realizar esses estudos, tendo interesse em realizar. Então, isso, de uma certa forma, dá acesso ao paciente, uma vez que a lei brasileira os protege ao final do estudo, de continuar com acesso num programa de acesso pós-estudo. Então, eu acho que o cenário mudou muito nos 10, 15 anos últimos passados, né?
Doutora, outra questão que a gente tem bastante dúvida: qual é a média do atraso desse diagnóstico no Brasil? Quanto tempo demora ainda hoje, nos dias de hoje, para um paciente conseguir esse diagnóstico, pelo seu conhecimento, pelo seu centro, pelos pacientes que a senhora atende? A senhora tem essa informação?
Olha, no meu centro, eu tenho, em média, isso eu levantei há um tempo atrás, uma média de até 5 a 6 anos para que o paciente alcance o seu diagnóstico. Isso é uma média, né? Tem aqueles que alcançam com 1 mês e outros com 10, 11, mas em média eu cheguei a esse número, que não é nada bom, né? E também foi uma visão retrospectiva, ou seja, eu tenho a esperança de que nos últimos anos a coisa tenha melhorado. Mas eu cheguei a esse número, não é um número bom. Nós queremos que os pacientes sejam diagnosticados no máximo com 1 ano de início da doença. E a dificuldade vai ser tanto maior quanto não houver história familiar, porque se perdeu ou porque o caso começou muito tardiamente. Vai ser tanto maior quanto menos conhecida for a mutação. Então, uma mutação diferente da V30, ela quase sempre é desconhecida pela maioria dos médicos, e vai ser tanto mais difícil quanto mais incomum for a apresentação. Esperamos uma polineuropatia e o paciente abre com uma cardiopatia ou abre com uma doença mista. Então, todos esses fatores acabam gerando maior ou menor dificuldade. É óbvio que, por exemplo, as pessoas que já têm uma história familiar, que fazem teste precocemente, que são acompanhados pelo menos anualmente, elas têm muito mais chance de fazer um diagnóstico peri-início da doença, quer dizer, bem no início mesmo, até um pouquinho antes da expressão clínica da doença, porque nós vamos nos basear em pequenas alterações de exames, do que aqueles que não têm história familiar, que vão passar a ser o caso dentro daquela família que chama atenção para a doença.
E, doutora, eu disse quais são os problemas que a BIPAR, que os pacientes, a associação enfrentam. E quais são as dificuldades que os médicos têm para nos atender, para nos tratar com relação à amiloidose?
Bom, as dificuldades que a gente enfrenta são as de acesso também, né? Então, a gente quer tratar o paciente, sabe muito bem quais são os tratamentos disponíveis no mundo e quais aqueles que são comprovadamente eficazes, mas nós não temos que passar por várias barreiras de enfrentamento de agências regulatórias, precificação e tudo mais. Então é isso, nós gostaríamos de tratar livremente, uma vez que nós sabemos que os medicamentos são eficazes, mas não conseguimos. E outra dificuldade é a de levar a cabo esses estudos clínicos que envolvem um esforço enorme, porque nem sempre as instituições públicas ou privadas têm uma estrutura para que os ensaios clínicos aconteçam. Elas dão suporte, mas não existe no sistema uma estrutura já formada. E com isso, aquilo acaba sendo uma função a mais para aquele investigador principal, que tem que fazer toda uma administração de pessoal e de recursos, além do seu trabalho médico. Eu penso que nós estejamos já no fim do nosso tempo, então eu gostaria de agradecer a Liana, parabenizar mais uma vez a organização, and thank you for your attention.
Happy to share with you the situation of H-ATTR amyloidosis in France. I'm David Adams, a neurologist, founder of French National Reference Center for Familial Amyloid Polyneuropathy.
Hello, I'm Jean-Christophe Fidalgo. I am a member of the French Association Against Amyloidosis, and I am also founder and president of the Amyloidosis Alliance, the Voice of the Patient, which is a network of patient associations into the world. So, Professor Adams, could you tell us how many patients are suffering for H-ATTR amyloidosis in France?
Actually, we think we have more than 2,000 patients affected with this disease in France, probably 600 affected patients, and also probably 1,400 people, carriers of this candidate to develop the disease in the next years.
Can you tell us the major milestone in the history of amyloidosis hereditary form treatment?
Next slide. Yes, the first patient with ATTR amyloidosis with polyneuropathy were diagnosed 30 years ago in France, so it's not so far. And after that, the main diagnosis was biopsy of the nerve, and we identified with our English colleagues that it was due to a TTR gene mutation, and we sent initially in London the samples to do the correct diagnosis. We developed in 1995 the laboratory to test the TTR gene testing to prove the diagnosis. And progressively, with the help of the nerve biopsy and TTR gene testing, we identify more and more cases in France, in different countries around Paris, but in every department and region in France. It was very complicated at the beginning to make quick diagnosis, maybe sometimes 3, 4, 5 years to do it, but actually we can do it very easy and quickly with blood samples when you suspect a case, and within 2 weeks we can have the results and say, yes, you have mutation of TTR gene in this disease. So we make very important technological advances. We develop a national network to be very comfortable with the diagnosis in different regions from France in 2010. And we developed genetic counseling also. And actually, we conversely to Portugal with only 1 mutation, we have now more than 50 mutations. So in France, we are very happy and lucky because we have total complete social security. And we have, with Jean-Christophe, development of a very strong association. Paulette Giron-Bistein and more recently, Association Française contre l'amylose in 2009. And so we all together, we work to be more and more better for the patient in the management and to the care of the different patients identified in the France.
Can you tell us about the different treatment which was available for this disease?
Next slide. This is a map to show how the network works around the national reference of Paris, and we have different regions in France where we have specialists able to do the diagnosis, even in the West Indies, as you can see. And also you will see the diffuse variants of TTR in different areas in France. It's not the same mutation in the north, in the south, but you can suppose any department and in any town you can have amyloid deposits, amyloid disease. Next slide.
So what is the evolution of the treatment for this disease?
The first one, it was a heavy therapy. It was a liver transplantation proposed by the Swedish teams in 1990, and the first one was performed in France in Paul Brousse Hospital in 1993. The goal was to suppress the main source of mutant TTR. We have to wait for the first clinical trial in 2006 with testing Tafamidis, the TTR stabilizer, to do it, and it was a drug approved by the EMA, European Market Authorization, in 2012. So it was a drug with 1 pill a day, 20 milligrams. But the chance of liver transplantation in late onset people to make it was absolutely necessary to develop new therapies to control the wild type TTR, and it was the goal of the RNA therapy and antisense oligonucleotides in the different clinical trial, and it was a success. So in 2018, we have 2 new drugs with inotersen and patisiran. And more recently, for the ATTR cardiomyopathy, the only one drug approved is Tafamidis, 61 milligram, since 2021. So we have access to all this therapy for the 2 conditions of polyneuropathy or cardiomyopathy.
What will be the future of the treatment?
So the future is to do the therapy as early as we can. So probably it would be to propose a preventive therapy in carriers. We have, as I said before, probably 1,400 carriers supposed to develop the disease in the next years, and we would be very happy to control it, to prevent the disease, and giving them a pill. them. So it will be a next clinical trial, and eventually a gene therapy for this disease to cut the DNA in the liver cells to be sure there is no more production of TTR wild type of mutant in the serum, and it would be a very exciting story for us in clinical trial.
Maybe next slide.
So we are very lucky in France. There are all conditions in France for care and support for H-ATTR amyloidosis. We have a multidisciplinary approach, access to fast genetic testing and genetic counseling. We have access to all disease-modifying therapies. And we have a reference center. We have strong national center and very supportive patients organization and French health ministry.
What are your hopes for this World Amyloidosis Day?
I hope this day will be the occasion to sensitize many doctors over the world to what could be ATTR amyloidosis, to diagnose this early and to propose therapy when it is possible. So, Jean-Christophe, you're also ATTR patient with polyneuropathy. You belong to the board of the French very active patient organization against amyloidosis in France. It's many years, but also your patient. So, what are in your case the greatest challenges you face?
So the disease has many impacts on the body, the feet, the legs, the balance, the strength, tightness. It touches also, in my case, the heart. I have a gastrointestinal disorder and the eyes. So it's not easy to manage so many organs which are affected, and especially when it's creating some pain. I was lucky. I had many of the treatment you introduced to us, but currently the treatment are slowing down the process, the progress of the disease, but not stopping it. And there is currently no mean to be cured, no mean to really recover. So this disease is creating disabilities, and you need to do with that.
What are your hopes for this World Amyloidosis Day, Jean-Christophe?
I hope that this World Amyloidosis Day will make the disease better known by all the physicians in the different countries, because main issue is the time in between the first symptom and the diagnosis, which is globally for amyloidosis, which may reach 4 years. So the more the doctors will know about this, the quickest they will orientate the patient to the good specialist, and the earliest they will get the good treatment. I hope also that this day will give the opportunity to talk about the disease within the families, because in this case, we are talking about hereditary form. So when one patient is diagnosed in a family, he has to transfer this information to the different members so they can get an early diagnosis.
How does a hereditary amyloidosis patient go about their daily life?
I talked about tightness, so it has a strong impact on the professional and daily life, especially when the muscle strength is decreasing. So it becomes more difficult, in some cases impossible to do a physical job, and so the daily life is modified. So especially regarding sport, physical activity, which are really necessary. You need to adapt what you do, trying to be active every day. So for walking, it means that you need progressively to use a walking stick, but still force yourself to do something. And for many reasons, also the social life is reduced. So in that case, the caregiver role is really key to help the patient keep having mental strength and keep on fighting against the disease.
And what is the patient pathway?
So it can be very chaotic with many consultations with very different specialists until the right doctor is found, especially at the very beginning of the disease. And when you have you encounter a neurologist or a cardiologist, then that's really the key to get the diagnosis. And after, when you have the treatment, I talk about the different organs which are affected. So this means that you need to have a consultation as well with many different specialists, in my case, neurologists, cardiologists, ophthalmologists, hepatologists, urologists. So that's quite a very busy agenda to see all those doctors.
Okay, Jean-Christophe. So thank you very much for your attention.
Thank you, Professor, for your participation to this very important webinar and World Amyloidosis Day.
Bonjour. Bonjour à tous. Nous sommes donc en présence d'une patiente qui est originaire d'Afrique et on va parler des amyloses héréditaires à transthyrétine sur le continent africain. Voilà, donc je vais poser une question à Madame M. Quel âge avez-vous?
J'ai 55 ans.
Et vous êtes originaire d'Afrique alors?
Oui, je suis originaire du Congo démocratique, Congo-Kinshasa.
Depuis quand vous êtes en France?
Je suis en France depuis 1994.
Et vous êtes atteint donc d'une neuropathie amyloïde héréditaire?
C'est ça.
Qui dans la famille donc avait la même maladie que vous?
Dans la famille, quand je suis venue, c'est mon frère qui m'a fait venir ici, qui était malade de l'amylose. C'est après qu'on a vu les symptômes avec maman aussi, elle en avait. Ma soeur et mon petit frère, ils sont tous décédés.
Et votre mère est décédée à quel âge?
À 59 ans.
Voilà. Et votre frère?
39 ans.
39 ans.
Ouais.
Et donc votre frère, il est venu en France?
Oui, oui, il était...
Et donc c'était en 94?
Oui, c'est ça.
Et il a eu un traitement pour sa maladie?
Oui, il a été transplanté.
Transplanté de
foie.
Du foie.
Oui.
Et avec ça, il a été guéri ou?
Non. Bon, apparemment, on voulait sortir de l'hôpital,
ouais. Mais
il y avait une infection qui s'est...
Et il est décédé après la greffe de foie.
Oui.
Voilà.
Et j'ai ma soeur aussi.
Et vous, donc, vous êtes en France depuis 94. On a découvert quand la maladie?
La maladie, on l'a découvert en 2017.
D'accord.
Et depuis longtemps, j'avais des symptômes.
Voilà.
J'ai maigrissé, des diarrhées.
Et donc on a mis un traitement contre l'amylose?
Oui. J'ai commencé par Vindacel.
Oui.
Et puis maintenant, je suis en piqûre des Patisiran tous les 3 mois.
Donc des médicaments qu'on a en France?
Oui.
Voilà. Combien d'enfants avez-vous?
J'ai 4 enfants et j'ai mon fils aîné qui a 35 ans, qui a la même maladie que moi, qui a commencé les traitements.
D'accord. Et toute votre famille n'est pas en France?
Non, non.
Ils sont au Congo?
J'ai mes frères et sœurs qui sont au Congo, à Kinshasa.
Oui. Quel âge ils ont?
Le plus aîné a 62 ans et le plus jeune a 45 ans.
Et ils ont tous des enfants?
Ils ont tous des enfants.
Et donc, est-ce qu'ils sont suivis pour l'amylose? Est-ce qu'on a détecté, recherché l'amylose? Est-ce qu'on a donné des traitements?
Non, j'ai mon petit frère qui vient de décéder le mois dernier, qui avait l'amylose. Et on n'a pu rien faire pour lui.
À quel âge?
Il est mort à 52 ans, il était professeur d'université, il était un grand avocat. Il a essayé de se faire soigner comme il a pu, mais ça n'a rien donné. Il est mort.
Et qu'est-ce qui... Oui, donc la situation est très difficile. Donc, ils n'ont aucun traitement, aucun centre de diagnostic.
Il n'y a rien du tout. Rien.
Alors, qu'est-ce qu'il faudrait faire pour essayer de les aider alors?
Pour les aider, je crois qu'il faut commencer d'abord par un centre pour détecter la maladie. Après, voir avec les neurologues qui sont sur place pour un suivi, même commencer avec les comprimés, les Vendakel.
Oui, parce qu'aujourd'hui, il n'y a aucun traitement possible.
Il n'y a aucun traitement, il n'y a rien. Les gens, ils meurent comme ça.
Donc, c'est vrai que le continent africain, c'est 1,3 milliard d'individus. Donc, c'est vrai qu'il y a a priori 4% de la population qui aurait cette mutation particulière ILE 122. Et on voit que la population dans tous les pays africains va augmenter dans les prochaines années. Donc, du coup, il y aura beaucoup plus de patients potentiellement atteints de cette maladie. Diapositive suivante. Et comme on voit sur cette diapositive, l'accès au diagnostic est très compliqué. Il n'y a pas un centre de référence de l'amylose comme on a en France. Il n'y a pas un réseau. Ce n'est pas possible de faire des tests génétiques. Donc, on ne peut pas dépister dans la famille les cas qui sont atteints. A priori, il y a une mutation, la vôtre, qu'on a repérée au Congo-Kinshasa. Il n'y a pas de sécurité sociale pour payer des traitements chers. Et puis, il n'y a pas d'organisation de patients contre l'amylose.
Pas d'association, il n'y a rien.
Diapositive suivante. Voilà, et on voit tous les traitements disponibles en France. On a la transplantation hépatique, le Tafamidis, le patisiran, l'inotersen, le Tafamidis 61 mg pour les formes cardiaques. Aucun de ces traitements n'est disponible. Non, diapositive suivante. Et finalement, l'accès au diagnostic et aux soins dans l'amylose héréditaire est quasiment impossible en Afrique aujourd'hui. On est en 2021. Il y a des vrais besoins pour cette maladie qui touche sûrement plusieurs centaines de milliers de patients. Et la situation elle correspond à celle qu'on a connue, nous, en France, en 90. C'est-à-dire qu'il y a une trentaine d'années de retard par rapport à la France. Et au minimum, a priori, il y a besoin de faire du test génétique et puis de disposer au moins d'un traitement disponible pour changer les choses. OK. Je vous remercie beaucoup à tous pour votre attention. Et on remercie Madame M d'avoir participé à cette interview. J'espère que ça pourra aider tous les patients africains.
Buenos días o buenas tardes según corresponda. Soy Luis Durán de la Asociación Venezolana de Pacientes con Amiloidosis Familiar. Venezuela hoy atraviesa una crisis significativa en cuanto a lo político, económico y social que según muchos expertos es sin precedentes. Situación que en los últimos años ha venido agravándose y que indiscutiblemente afecta a todos por igual. Tanto la población común como el gremio médico ha tenido que emigrar o ha tenido que emprender un éxodo masivo hacia otros países en búsqueda de mayores oportunidades de empleo. La situación de la salud se dificulta cada vez más. En tiempos de pandemia, el acceso a tratamientos es sumamente costoso. Para tenerlo como una referencia, aún más el acceso a tratamientos para enfermedades raras, para otras patologías de mayor prevalencia, como el cáncer, se dificultan muchísimo. Situación que se ha planteado incluso en distintas tribunas internacionales. Hoy por hoy, los pacientes con amiloidosis familiar, que asciende, según los registros que logramos tener, a unos 15 pacientes. Sin embargo, esto puede ir incrementándose en el tiempo, debido a que muchos de estos pacientes que ya tienen diagnóstico tienen hijos. La situación para todos se torna crítica. Por ejemplo, un examen genético para determinar si la persona es portadora del gen mutante o de algún gen mutante para amiloidosis cuesta alrededor de $1.000. Un trasplante hepático asciende con el preoperatorio y el postoperatorio a unos $100.000. Y tenemos paradójicamente que el salario mínimo en Venezuela el día de hoy es de $1.60 apenas. Esto es al mes. $1.60. ¿Qué se compra con eso? Absolutamente nada. Todo esto como referencia para dejar en claro cuán difícil es el acceso a tratamientos médicos en nuestro país. Si ustedes saben, ustedes conocen bastante bien cuál es el costo de los medicamentos para tratar la amiloidosis. Solamente aquí los venezolanos con este diagnóstico poseen tratamientos paliativos. Algunos de estos pacientes, de estos 15 pacientes que mencioné, ya fallecieron. 6 de ellos fallecieron, 3 lograron acceder a tratamientos a través de ensayos clínicos, 3 de ellos no lograron ningún tipo de tratamiento y el resto de los 9 aún continúan sin poder acceder a ningún tratamiento ni siquiera a medicina de carácter compasivo. Nuestro llamado es sencillamente que, considerando toda la situación que atraviesa nuestro país, lo costoso que resulta cada tratamiento, la distancia que hay entre los centros de tratamiento y las residencias de los pacientes, por ejemplo, que las farmacéuticas, la alianza y todos aquellos entes que puedan servir de enlace para que los pacientes venezolanos logremos acceder a un tratamiento paliativo o un tratamiento de uso compasivo, algún ensayo clínico que permita mejorar nuestra calidad de vida, es el llamado que hacemos. Sencillamente queremos continuar viviendo, queremos seguir luchando por la causa de la amiloidosis, queremos que se cumplan cada vez nuestras metas. Ese es el llamado que hacemos hoy día. Muchísimas gracias y que la oportunidad sea para todos un logro efectivo en el mundo.
We are here to discuss about all the speeches that were given by patients and medical doctors. I see that we currently don't have any question from the floor, so I may ask a first question to run the discussion. And first of all, I would like to congratulate all the organization. It was a great to see all these countries that are currently participating to this day, and really that's very impressive. So that's first point. Second point, I was really impressed by regulatory issues and the economic issues that currently patients and doctors are facing in all over the world currently, and we can tell that in France we seems to be very lucky. We seems to be very lucky, and so maybe my first question actually come from yesterday evening, and we had a wonderful evening about amyloidosis, and one patient asked me about the genetic testing and the usefulness of genetic testing. So maybe it will be a question for Marcia or David, and told me, well, given the fact that treatment will be the same whether or not I have a mutation, what is the usefulness of being tested and having a diagnosis of TTR amyloidosis, and because if it's a wild type or if it's a variant form, the treatment will be the same. So maybe Marcia or David.
I can open. We have more data on the efficacy of the treatments on the TTR amyloidosis. More recently, we have wild type TTR and diagnosis with and therapy with 61 milligram of Tafamidis, but we have a long experience of 4 different treatments: liver transplantation, Tafamidis, and RNA therapy, and oligonucleotide antisense. And with the clinical trial, we know what the drug can do for the neuropathy. We don't know exactly what's happened with the cardiomyopathy, and the future clinical trial will help to see what's happened, slowing the disease and so on. So I think it's very important to have a genetic test, because it's not the same if you have a sporadic wild type versus a familial disease, and genetic testing for all the family.
Yes, if I may add something, it's not only important, it's mandatory because you need to know what disease you have exactly. The prognosis and response to treatment may be completely different depending on the mutation. And of course, you need to know if you have the mutation inside your family, and make your descendants being followed by medical doctors, and being able to detect the diseases as early as possible. So it's very important to get as accurate diagnosis as possible.
Okay, I think you raised important points, especially the fact that when you do diagnostic testing, you're allowed to diagnose not only a patient but a whole family, and that you allow as well early diagnosis. And you raised the point that there was a delay, a 5 years delay, I think, in Brazil. You told about us, and between first symptoms and diagnosis. I think in France we're currently about 2 to 3 years between. It's the average delay between first symptoms and diagnosis, but it could be much longer, and it's very important to have the genetic testing because it allows further diagnosis for all your family. Maybe Giovanni, you're sharing the session with me. Maybe you have a comment or a question.
Absolutely, yes. Thank you very much, Dr. Olga Lorondo, for be the co-chairman for this session of the afternoon. Yes, more than a question, I have a consideration that following both presentation speeches from Professor Adams and Dr. Marcia Waddington-Cruz came out, and for us from the patient point of view is very important. We start with a chart that make a comparison between 190 and 2021, the world with how was the different situation in the world with the detection of of the disease of the amyloidosis. And another important thing that raised up also from the interviews that has been conducted is also the different situation that we may have in a country, European or Northern of the America, and the situation that the Dr. Marcia Cruz highlighted in detail, speaking about the Brazil and moreover Argentina, Mexico, Chile, and Colombia. And also don't forget at the end the interview that Dr. Professor Adams made about the situation in Africa that at the moment is absolutely unknown, because we know that there could be some patients, potentially there are patients not only in the Congo-Kinshasa area, and also part the great problem that Oscar faced in Elvis faces in Venezuela. So sorry, after this long introduction, the important thing is what we, like players, I mean the doctors, the patient organization, and also the pharma company should do for really try to task and to give the person, the patient, the possibility to get the drugs, because in some countries it's frustrating to have approved drugs but not yet given to the patient. Which is your idea?
If I may say something, thank you very much for this kind introduction. I feel the discussion is all around the price of the drug. I understand all the costs involved in developing a new drug from years and years of study and investments. I understand all this, but we need to put things into the reality. And right now we are facing the causes of the pandemic. So we don't expect a drug to be bought by a government in Africa, let's say, I'm not mentioning my continent, but by the same price or by a price that would be not unreasonable. So we need to have some humanity behind all this and try to make things into real. Otherwise, as Adam said, we'll be delayed 30 years and we'll be watching into this. I don't know if we got into detail what the patient from Venezuela told us step by step. You know, as a human being, it's something that is not acceptable. It's not acceptable. We need to do something about, or not only think that it's about the price. It's about the price. And we can do nothing about this but accept. That's my opinion. I feel very sorry about this. I don't know how to live with this.
I may add some comment. We had a dream in 30 years ago to get a treatment for each ATTR polyneuropathy patient, and we started with the liver transplantation and so on, and finally any French patient had access to any treatment. As treatment now for amyloidosis. I hope for after this World Amyloidosis Day that the next World Amyloidosis Days we need for every amyloid patient in the world could access to at least one therapy wherever he is, in Africa or in South America, and it's not acceptable to have no treatment for this patient. As soon as diagnosis is done, we should give a pill, something, but we can't stay like this. This is my message.
Yeah, I can comment also. So for the Amyloidosis Alliance, we are conscious about those difficulties, and in our future objective, we want to help and to play a role in deploying some treatment for all the countries. And as Professor Adams said, we really need to have at least one treatment for all the patients in the world. So we will try to progress and to help for that.
Well, in that sense, we are very happy in Brazil to have Tafamidis for polyneuropathy, at least completely covered by the government since 2018, and around 200 or more patients being treated in the whole territory. So this is different from Africa, for example, or from Venezuela. And all the trials going on, so patients somehow they have access to other drugs, but
we can imagine something like vaccine for anti-COVID-19. Recently, the North countries sent doses of vaccine to the Africa and so on. Maybe we can imagine something like that. Some doses of anti-amyloid therapy for patients for all through the continent, and especially even in South America. Maybe we can work on this. It would be a nice approach. Maybe Europe can help to do that.
In fact, I'm thinking that we have through Fabio Almeida, that is in our board, some experience how you manage the situation in Brazil to get the approval, and I think that probably we may replicate this approach, but again to have the local situation, and we need to have also the support not only of doctors but also from the patient, because they knew perfectly the situation, the current situation.
In this respect, maybe one other hope would be the CRISPR-Cas9 technique, because we may hope that it will be a definitive modification, and that we don't have to treat and retreat our patients repeatedly, and may cure the disease, at least for those patients who would have access to this treatment. But still, it's under evaluation. I was also very interested about what you told about the transplanted patients in Brazil. In Brazil, when you did liver transplantation, did you do as well a domino program? And did you transplant the livers from TTR patients to other patients who needed urgent access to a liver graft?
thank you for your question. Yes, there are very good centers, liver transplantation centers in Brazil, in Rio, in São Paulo, in South Brazil. They are very active, and they do domino transplantation regularly. But right now, patients who want to go to liver transplantation, who want to be treated by liver transplantation, the number is going down and down and down. So very, very few patients want to choose liver transplantation as a treatment. But centers are very very well organized and able to do both liver and abdominal liver transplantation.
But you have so to face as well to the problem of following these patients, abdominal transplantation liver patients, that sometimes could develop some, they have been saved by their liver, their new liver, and then 10 years later they're in another disease, a new disease that is life-threatening as well. So
Exactly. So I have some difficulty following that. I've been trying over the years, but for some reason they get very attached to liver transplantation centers, but not to amyloidosis and other medical doctors' centers. So, but even a liver transplantation surgeon would very much like to be able to treat them for a future amyloidosis, or to prevent amyloidosis, or even to treat the the fat patient with liver transplantation together with a stabilizer or anything else, but it is difficult. For now, it's difficult. I don't know if patients are getting access by suing the government or suing their private insurance, but in general, it's a hard way to achieve. It's not regular. They will need to fight with the as you told us, Dr. Giovanni told you, it's a joint work between patients, between associations, between academies, and between centers. It's a group work. We cannot work alone. If it's not a task, if it's not a priority of this academy, of this society, of this medical association, and the patient association, and the group of medical docs at the center, we want to achieve anything by our own, by talking alone.
Okay, I don't know if there is other comments. I didn't see any other question from the floor. So if everybody has something to add, maybe at the time. Otherwise, it's maybe time to close the session. So once again, I want to thank. Okay, Jean-Claude.
Yeah, maybe one word regarding the communication within the families. As Dr. Marcia Waddington-Cruz told, we need to communicate within the family. But this is not a natural process. Sometimes the family member realize and then they want to go quickly to the genetic testing, and some other are reluctant. They don't want to hear about that. And in this situation, when they have some children, they may be informed about the disease in the family very late. So this is something we need to improve, and we try to bring to the families some tools which they can use to ease the communication, try to convince every family member that they need to be tested.
Actually, it's a critical issue because when you're tested positive for a TTR mutation, you have as well some social consequences. For example, it's very difficult to borrow some money to the bank. It could be difficult to find a job. And I think we have to work more on the social consequences of carrying a TTR mutation. I remember that a Portuguese patient I was discussing with and telling me that when you're from a family with, polyneuropathy, when you will go to dancing on the Saturday night, the fathers won't let you dance with your girls, with your daughter, with the daughters, because you're from a family that has the curse of being involved with this kind of mutation and this kind of disease. So we have clearly to work on the social acceptance and the fact that even if it's a terrific disease, there are some really great hopes for being treated and allowing some patients to have a normal social life and a family life.
Yeah, this is also another issue, but obviously we need some more time to talk about this. But I totally agree with you that happens sometimes that there are situations like this in families. Well, I think that if there are no other questions, I may thank on behalf of the board of the Amyloidosis Alliance, all the panelists, all the person that has contributed to the testimony. And obviously, we would like to welcome you next year to 2022, the 26th of October. And of course, there is another session if you are interested to follow. And thanks again. Arrivederci.
Bye. Thanks.
Thank you.
Bye.
Thanks. Bye.